Using this video, we can see that how delicate the cataract surgery has become. This was a lady with significant cataract, basically a nuclear sclerosis, to be operated for her visually significant cataract. A clear corneal incision is being placed at the steep axis so as to reduce the pre-existing corneal astigmatism, and this has to be coupled with the opposite clear corneal as the total keratometric astigmatism is nearly 2 diopters. Instilling intracameral lignocaine so as to anesthetize the ciliary body and iris and make the surgery painless for the patient. Inflating the anterior chamber using viscoelastic, this is methyl cellulose, and proceeding for a capsulorhexis. Capsulorhexis is not very difficult in these individuals because the capsule is neither very elastic and not very fragile. So this becomes a very routine and a very effortless capsulorhexis for an experienced surgeon. So once the rhexis has been finished, we proceed on to making a side port, for which I prefer to use a MVR blade. And here this is the rewind, and please observe that how the MVR blade enters into the anterior chamber and there is inadvertent hit on the capsulorhexis border. Although it doesn't result into any complication just now, but when performing phacoemulsification, there will be some change in the scenario which we'll appreciate at the end of the nuclear disassembly and consumption. So not being a very hard and a very large nucleus, so bisecting it using a horizontal chop technique, and a half of the nucleus has been consumed. Proceeding for consuming the remaining half, the chop is not very complete but doesn't matter, and we have consumed the nucleus. And now removing the epinucleus using the phaco probe itself, which is very much possible and safe in these scenarios, and now going for the removal of the cortical matter. And this is where we can observe that the point where the capsulorhexis border was hit by the MVR blade, it has extended, and though it has not resulted into any unwanted complication, but now the capsulorhexis border is not intact. So basically it is a issue when you are doing phacoemulsification, because this extension, if it progresses posteriorly to the capsule, it may result into vitreous prolapse. Here this has not happened and we are lucky in this respect, and here we can see the opened up capsulorhexis. So no any change in the surgical technique has been planned now, and we are proceeding with implantation of a monofocal hydrophobic single piece IOL, and the leading haptic and now the trailing haptic both go into the bag, and the desirable position of the IOL is such that there should not be any stress in the area where the rhexis is compromised, making the planned opposite clear corneal incision to relax the steep meridian and reduce the corneal astigmatism, and proceeding for removal of the viscoelastic material. I always prefer to make my clear corneal opposite incisions when the irrigation aspiration process is going on, because the probe provides me a very good linear impression about the point where I should be making this opposite clear corneal incision. Hydrating the wound, checking the IOP, and the surgery is finished. Thank you.